have genetic testing. The problem is that one thing that we didn't really mention in the presentation is that in the family of 10 children, unfortunately, after the first year, the mom actually left the family. So we couldn't actually get consent for a long time. But I would love to actually know what the reason is behind the corneal changes, especially because we know from the family history that seems to be that the dad was normal, but multiple children in the family affected with anterior segment changes, and mom had some finding. But unfortunately, she did actually not feature in the care of the child anymore. I'm just going to share my screen real quick. In 1 second. And while I'm just sharing the screen, I want to just say one thing that's in particular, which is that many of these cases that we feature today, they were not things that I knew how to do before I joined Steiner Institute. I really want to give credit to those people who gave me mentorship and also taught me how to do these cases. Very simple, for example, is that I never did a goniotomy really on my own until Dr. Coleman walked me through the first case. And now I'm doing a GAT. Similarly, you know, I never really suture a lens. And then I watch Kevin Miller, that he does his own thing. And then also some YouTube videos too. And then that now I can do these cases. So without the mentorship of with the faculty here, I would never be able to do this. So today's talk is pediatric ocular surface inflammatory disease with clinical features and practice patterns. This is a topic that I presented maybe about 2 years ago, and at the time, Wordle was a hit. I remember that Dr. Aldave really didn't like me using this title because he thought he was going to do something about it. And then I steal it from him. So, but I thought, well, why not bring it back, you know, for a second time? For disclosure, I have a research support from Dompe, and I'll talk a little bit about off-label use of medications. But I want to just go back a little bit and think about, you know, how, you know, who I am and so on, so because many of you don't know who I am because many years have passed, and some of these residents have no idea why I talk funny. And I want to remember, I want to remind everyone that every time I remember in the past when Dr. Dima introduced me to the audience, he'll remind everyone that, you know, Mr. Simon Fung comes from the England for training, and he's not a doctor, he's a Mr. And there's a reason for that. And, you know, usually you think about England, you think about afternoon tea and you think about Union Jack, a big fan. But we surgeons, we are not doctors in UK because historically, we are barbers. We are barber surgeons. And we're very proud of that. We want to be different from doctors. There's a bit of tribalism going on. And on the right-hand side, the picture is actually Sweeney Todd and the barber surgeon. I promise I have not done that. That is not in my surgical logbook. But one thing that I did learn in my medical school because of that tribalism was this phrase, which I still remember in my mind, that in a surgeon's gown, a physician may make some significant progress. The fact that I feel very proud to present this here is because many of you, or most of you, although I'm very careful not to look at Dr. Holland and Dr. Sadoun here, many of you are surgeons as well, so maybe you feel a little sense of pride when you speak about this too. But I'll come back to this quote later on to saying why this is something that I like to keep hold in my mind when I talk about these kind of conditions. Now, as I go through training, first in Oxford and Moorfields and later on in Toronto, I came across a lot of children with inflammatory eye conditions such as this one, where they just have a lot of light sensitivity and red eyes for completely unknown reason until they come to the hospital. And really that sparks my interest in the pediatric ocular surface inflammatory disease. It's such a mouthful that I created an acronym POSIT, and now it's actually more in the literature. So that's actually good to hear. We don't have to keep repeating these 5 words all the time. So what are sort of POSITs? We need the top 3 diagnoses, just a reminder, vernal keratoconjunctivitis, which is an allergic condition. We see that a lot in this region here. Blephary keratoconjunctivitis is a bit of an inflammatory condition of uncertain origin. And herpetic keratoconjunctivitis. Of note that there's a lot of work done by our past chair, Dr. Mondino, on blephary keratoconjunctivitis before, and I want to give him credit about finding the pathogenesis and also the pathophysiology behind it. So because we didn't know a lot about these conditions, some of these simple questions that we actually yet to answer before we did any studies were just like how common these conditions are. In the past literature, we keep talking about they're very common. Many pediatric ophthalmologists will see them, 15, 20, 35% of population. But really in the country, how often are we seeing these cases? And we were fortunate enough to be able to leverage big data access from my colleague, Stacey Fernandez, and with the help of my medical student, Tanya Bahosian, and also the statistics department, Claudia Perez, and also a very youthful looking Fei Yu. We looked at all the Optum Lab data warehouse that contain over 200 million de-identified data records. And we looked at particularly pediatric encounters in the period between 2008 and 09, as well as up to 2018 and 19. And we isolated the ICD-9, ICD-10 codes for these three particular conditions and see, what the epidemiology is. And overall, we reviewed 6.5 million children, but looking at just 2018 and 2019, we found that the prevalence of POSIT was about 3.3 per 10,000 children. In the bottom of the slide, you see the breakdown of the age, gender, and race. Mostly, POSIT is concentrated in the age between 5 to 15. It's roughly equal between male and female, maybe slightly more towards the male side. And also for race-wise, this roughly, I would say, what you expect in a normal population, but seems to be a little bit more overexpressed among the Asian children. We also looked at the subtypes. Again, these are work that we have presented before, that we finally have a number, like an actual annual prevalence for each of these individual conditions. And just to put it into perspective, a pediatric cataract in the US is roughly about 1 in 10,000. So this kind of number is not something that a pediatric ophthalmologist will not see. They're not very rare conditions, even though they're thought to be a bit more uncommon. We look at the subtypes of each conditions. There are some important changes or differences in terms of age distribution, gender distribution, and also race and ethnicity. I think we all kind of know that for allergic eye conditions, such as the vernal keratoconjunctivitis or BKC, the more common in male. What we didn't expect was that there was a lot more Asian children affected by that condition. From the age standpoint, the interesting thing here is that the herpetic conditions seem to be more common as you see more older children, whereas for blepharitic keratoconjunctivitis and also vernal, the conditions again concentrate between the 5 to 15 years old. So just a quick summary about the things that we have presented before. The prevalence is about 3.3 per 10,000. Vernal is most common, followed by herpetic and then blepharitic keratoconjunctivitis. So POSIT differs in terms of demographics. And also what we didn't show here, but I can tell you that the demographics also changing if we compare 08, 09 to 18 and 19. Certainly it seems that the BKC is slightly on the rise, and also vernal keratoconjunctivitis is now becoming much more common among Asians. You're talking about 4 to 5 folds of difference. The work that we've done, we're fortunate enough to have been accepted by the Ophthalmology Journal, and now it's currently in press. And that's great. It's great to celebrate that we can do epidemiology, but there's always something more to do. And that's the time when I sort of go back to this quote, because you see this quote here, that the thing that I learned from sort of medical school really is an acronym to help us to organize our information. For the quote itself, it actually represents how you can describe a condition right from the incidence to demographics to the pathology and also symptomatology and prognosis. So what have we done so far that covers in terms of this acronym? Well, we had a publication looked at the epidemiology, so we've done that. So that's great. For etiology and pathology and pathogenesis, there's so many conditions within the POSIT that is like different cups of tea. Really depends on what you're drinking that you have different data. So we can't really use big data to help us to identify the pathology. And you really have to look at each condition one at a time. However, we can leverage big data to look at maybe the overall symptoms and signs and how they present, or how these children present to the practices, and also how they do in terms of outcomes. And that's what we did. So this is why we are bringing back this project as a sequel and say, well, what do we see if we use the big data analysis and look at the clinical factors? So the same team, the same successful team is coming back and looking at this time, particularly pediatric encounters between 2017 and 2019, there are additional inclusion criteria so that these children have to have at least 6 months of coverage before they were diagnosed with POSIT, and also over 3 years of coverage after the diagnosis. And by doing so, we created a cohort of 6,100 patients. And once again, we look at the demographics, and you can see they're fairly similar to the prior publication. So we're not necessarily finding anything different here. What's different, however, is really looking at the clinical features at the time of diagnosis. So this is when they come to the clinic. Now, the boxes highlighted in red are the ones that the most prevalent or most common finding in that role. So if you look at, for example, blepharitis, is significantly different between the conditions, and the most common condition that has blepharitis is blepharokeratoconjunctivitis, hence it's in red. And really, they're not anything unusual. You know, you see more blepharitis in BKC, that's understandable. It's in the name of the condition, right? So it should be. You see more giant papillae in the vernal keratoconjunctivitis. Again, that's understandable. And also, we also knew from the old literature that herpetic keratoconjunctivitis does have a lot of scarring and a lot of times of ulceration at the time of presentation, very different to what we see in adults. So these are known things, and we are sure by these findings because we're not, barking up the wrong tree. We're finding good data. We're not finding noise. What's more interesting is actually these blue boxes here. Why we are seeing so much giant papillary conjunctivitis in the blepharokeratoconjunctivitis group. Now, note that the cohort that we created, we only asked to label these children with the first diagnosis. It is possible that some of the children with BKC later on develop vernal and therefore have BKC also. But remember, this is only at diagnosis. So this is unusual how many of these, like 10% of BKC patients, have both BKC and vernal keratoconjunctivitis. In my clinic, I have never seen one. I think more likely explanation is that actually BKC as a condition is very confusing. There are many different sort of definition features, and it could be very diagnostically challenging for practitioners to recognize the condition at the time of the diagnosis. And giant papillae may have been wrongly associated with these children. The other two sort of surprising finding is that even though we do see a lot of scarring among the herpetic group, about 2% of patients in the blepharokeratoconjunctivitis group also have scarring and ulceration at the time of presentation. So 2% in a 6,000 cohort is actually a big number. And the fact that we're not even usually thinking about scarring and ulceration in this group means that we should really pay attention to these features among these children with blepharokeratoconjunctivitis. Amblyopia in this cohort is about 2%, which is roughly the population average that we expect to see. Now, if we look at the treatment that was given within the 3 years after the diagnosis, these are the things that they were given by the treating doctors. Again, there are some significant findings. So, for example, there are differences in the use of high-dose steroids across the 3 groups. And also there are differences in the use of systemic antivirals across the 3 groups. Again, I'm actually very sure by this. If I didn't see that there are a lot more kids with herpetic keratoconjunctivitis receiving antivirals, then we're not doing the right thing, right? So we expected to see a high signal in the HSK group using systemic antivirals. What we didn't expect is that there's actually a very high number of children using low potency steroids all the time. You're talking about 15% or so across all 3 groups of children, as well as high potency steroids. You're talking about prednisolone 1%, dexamethasone 0.1%. These are agents that could cause cataract or glaucoma in the long term. And if you look at the high potency steroids, the highest proportion of people needing to use steroids is actually, again, the BKC group and not the other 2, the vernal or the HSK population. One other thing that is slightly unusual is that we are seeing a very low rate of pickup rate or prescribing rate of topical immunomodulators. We're talking about topical cyclosporine, topical tacrolimus, or pimecrolimus. Those are 3 drugs that we looked at. And this is surprising because for vernal keratoconjunctivitis, there are well-established guidelines, treatment guidelines, that once children are shown to have vernal keratoconjunctivitis, and they are difficult to control. For long-term maintenance, we really encourage doctors to switch to immunosuppressants and therefore using steroid-sparing agent and try to reduce that steroid load in these children. The fact that it's only 1.7% of BKC children receiving topical immunomodulators means that either we have more education to do, they are not aware of these treatment guidelines, or there's an access problem. We cannot necessarily use medication for this particular purpose. Things may be changing because now in the last few years, there are there are two now dedicated medication for vernal keratoconjunctivitis that are steroid sparing, and therefore maybe the pickup rate will be higher in the future. But again, that's actually quite surprising, and that may explain why such a high usage rate of both high and low potency steroids among all three groups. Really, we have been fighting the fire using the steroids whenever it happens, but we haven't been really good at maintaining the control. And looking at the complications after 3 years or within 3 years after the diagnosis, again, many people get giant papillary conjunctivitis, many of them are BKC, many of them are BKC. So once again, highlighting that there may be some challenges in diagnosis, or maybe it's just that over time, because of seasonal changes, they accumulate more of this diagnosis. And then for scarring and ulceration, there were changes as well. More of them were, a lot more children in the herpetic group do develop now stromal scarring. A significant number have corneal ulcer as well. And again, the BKC group, 3 to 5% have ulceration and scarring, once again showing that it's not an insignificant number. The amblyopia rate is higher after 3 years. Maybe it's because of these diagnoses, but it's really hard to say because there are no, this is not really a causation analysis, it's more of a association analysis. So maybe that is because of the condition that more children in each group are becoming amblyopic. One thing that is very reassuring is that the serious complications such as corneal perforations or limbal stem cell deficiency, they have not really been found in the 6,000 children that we identify in this cohort. In fact, because it's so low, it's less than 1% of the cohort that we are not allowed to review which group has how many cases of perforations. All I can tell you is that they're not very common. And also, another surprising, although maybe reassuring, maybe surprising fact finding is that less than 1% of children diagnosed with these conditions had any kind of surgical intervention, including subconjunctival injections or amniotic membrane transplant, or even keratoplasty. So are we sort of neglecting these people despite they have corneal scarring and not really treating it? Or are they just not really serious scarring that we don't need to do transplant? We're not too sure. We always worry about the risk of amblyopia being a pediatric physician. So we look at the sort of regression analysis and looking at some of the risk factors that may predict the development of amblyopia after 3 years of diagnosis. So the factors that we found were significant were stromal scarring at the time of diagnosis at the baseline, and also any usage of high potency steroids. As you can see, the rate is somewhere between 1.6 to 2.4 fold or higher odds compared to the normal population. If you break it down into the individual conditions, once again, the two that lights up in terms of having a higher risk of amblyopia are herpetic keratoconjunctivitis and also blephary keratoconjunctivitis. Both of them are showing that if you have scar at baseline, you're more likely to be amblyopia. So in terms of clinical features and practice patterns, I think this is kind of the summary that we have. We know that they have distinctive presenting features. We know that the corticosteroids were frequently used, at least in this group, and also by large extent by a lot of the majority of the US physicians who treated children who enrolled into the Optum Labs database. The topical immunomodulators were rarely prescribed. Maybe we should do a better job at guiding doctors to use these treatments and not necessarily use steroids. And stromal scarring is associated with amblyopia. So that's great. So we now know that the condition, how they present, how they behave, and also some of the outcomes as well. But what I didn't tell you is that just because, you know, just like what we do, right? In medicine, time moves on and we develop our ideas more and we add on to our medicine and understanding. Just even with this mnemonic, we have actually introduced newer letters or newer words to help us to describe conditions even better. So now it's even more bogus kind of claim that if you dress in a gown, that you can make really good intervention in tiny prognosis. So what are the three words that we introduce, and what do they mean? Well, we want to know the definition of condition. We want to know the investigations that we can use for conditions, and we also want to know the treatment for the conditions, which we didn't really talk about in the original mnemonic. Now, we've gone through a lot of the three conditions already: herpetic, vernal, and also the blepharokeratoconjunctivitis. It would not be possible for any person like a researcher like myself to target all these conditions and really describe all of them. So I had to decide to pick one that is probably the most interesting to me, one that I've seen the most, but also one that has received relatively a lack of attention, and that would be blepharokeratoconjunctivitis. Why do I say that it's lacking the attention? Well, first of all, let me show you this. This is a page directly from the iWiki, the open source, freely available online webpage, talking about vernal conjunctivitis. There's a whole page on it. There's a picture showing you what it is. There are appropriate ICD-9 and ICD-10 codes, so you can definitely do the proper billing. Great. You look at the blepharokeratoconjunctivitis group, there's not even a picture that will show you what it looks like. There are a number of different codes that really confuses not just the parents, the patients, but also the physician. What exactly is this condition? How do we diagnose it? How do we actually help these children more and not randomly give them these funny numbers just because we have to do some billing? So to tackle this problem, we want to know what has been done first of all. So far, the definition of BKC in the literature has been mostly subjective. We don't really have any objective kind of definition of the condition. And also we have many different classifications, but mostly they're on severity of the condition. Because these classifications, as you can see, they're also based on sort of physician classification or judgment. They have pretty poor repeatability, and none of them are actually validated. So one of the few things that I feel quite happy to contribute with many other experts. I would say this paper was done by 13 other experts and myself. I'm not an expert because the other people here, for example, like Dr. King Sheeter, Dr. Donald Tan, these are like really sort of the megastars in the ophthalmology field. But really what we did was we come together and did a Delphi process and really trying to nail down what BKC is, what pediatric blepharokeratoconjunctivitis is. And we went through multiple rounds using the Delphi consensus process, and we have come up with diagnostic panels of the condition itself so that we can use these reference pictures to help doctors to diagnose the condition. We've also devised a diagnostic criteria because we recognize that some children may not have the full-blown picture of the blepharokeratoconjunctivitis. Now, the condition itself has three different words: blepharitis, keratitis, and conjunctivitis. And we know that we think that everybody has all three components, but actually many kids do not always have corneal involvement until later on. So, and that's why we developed this new diagnostic criteria where some of them are definitely or definitive BKC children where they have features in every single aspect of the anatomy, the lid, the cornea, and the conjunctiva, whereas some of the other children who may just have the lid and the conjunctival signs, but not quite the corneal features, they are what we call the BKC suspect. Maybe they will develop a full-blown condition, maybe they would not, and this is something that we want to look into in the future and see how many of these will develop the full-blown disease later on. Talking about investigations, how can we actually follow these children in a better way? Right now, as I said, the only way that we can assess these children are using subjective means at the slit lamp. And if you have seen a child with active blepharokeratoconjunctivitis, you know that the condition is very photophobic. It's almost impossible to elicit all the clinical signs and then track them over time. So what we want to do is to see, can we use any biomarkers to label the condition and follow it over time? And really in here, we have to leverage our sort of dry eye armamentarium and use some of the dry eye diagnostics to try to see if because they're detecting ocular or surface or tear film inflammation anyway, can we use those tools in children to follow the activity of BKC? And with the help of my fellows, Ralph Placencia, who's now back in Peru, and then also Pompon Patarajirapon, I got the name right, from Thailand, who's currently with me. And also, I have to give a big shout out to Dr. Wei Lin Sang, who really helped with the organization of the study. We looked at 3 different things that we can use to stage or look at the activity of the condition: a metalloprotease 9, MMP9 testing assay, tear osmolarity, and also the tear film surface characteristics analyzed by imaging. And some of the sort of early results that we can show, and also that Dr. Patarajiravapun is going to present in the ARVO coming this year, is just looking at the performance of these biomarkers in this group of children. The MMP9 testing is very sensitive in picking up BKC, but maybe it's not so good at tracking activity because it's always positive, even among children who have very little clinical signs of activity. Unfortunately, the tear osmolarity may not have been that useful. We didn't find any significant results between the BKC group and the control group. However, on the other hand, using the ocular surface analysis, like imaging analysis, and looking at the ocular surface redness, how red it is analyzed by the machine keratograph, we found that actually we were able to distinguish the BKC group and the control children, and the difference is significant. Now, apart from just tracking activity, we want to know what the impact is. We talked about that many children with BKC can have a lot of stromal scarring and ulceration, and we think that may be related to amblyopia. Not all scarring or corneal scarring are bad enough to block off the pupillary axis, obscuring vision. So why are they seeing so poorly and developing amblyopia? So we want to investigate the impacts of BKC, and really we're focusing on the corneal topography assessed by the corneal tomographer Pentacam. So again, I leverage the help from Raul Pesencia and also my medical student Tanya Bahosian, looking at the sort of topographic analysis in these children. So in total, we looked at about 21 eyes or so in the collaboration with Toronto Sick Kids. And we found that many of the keratometry values became actually statistically significant compared to a control cohort. The BKC children tend to have much steeper keratometry values, much higher topographic astigmatism. And also the cornea is very irregular, so much so that if you look at the bottom panel, the bottom table, those are the indices that we usually use to diagnose keratoconus. Many of them actually showed up as if it's actually abnormal, even though there were no clinical ectasia. So we know that the cornea in the children with BKC can be very irregular, and that may be the reason why they're developing so much visual impairment afterwards. And then finally, just a brush about on the treatment of BKC. We talked about the fact that we're not using enough steroid-sparing agents. So can we actually use immunosuppressants not for vernal keratoconjunctivitis, but for BKC? So in a small cohort, small retrospective course study that we're doing here, I have 4 lovely trainees who worked with us. That is Tiffany Huang, who is now currently attending in Emory, Leanne Dalazade, who's now a plastics fellow in Texas, and then Raul, as well as our current resident, ISTAR resident, Elisa Ma. We're looking at the outcomes of 21 patients who had received the cyclosporin A 0.05%, only this agent, nothing else. And we look at the symptoms duration before the first visit, and also the time from the first visit to starting these steroid-sparing agents. But what's more striking is actually the outcome of this treatment. If you just look at the pre-treatment and the post-treatment, we can see that by using the topical immunosuppressant instead of a lot of the steroids that we are otherwise exposing children to, we can actually have a significant reduction of photophobia in these children, conjunctival injection, pupillary reaction, and keratitis. And also, most importantly, the number of flare-up that they get per year, and also the number of clinic visits that they have to do per year. And really, the last 2 is the most important, because really, when you have to take a kid to a clinic, it means there are time off school, off playground, and off their normal social activities. So really, having that significant reduction is something that I think is very important in helping this group treat children. So I think in summary, I think we talked a lot about the condition, really looking at the definition, the epidemiology, the symptoms, the treatment, and the complications. And I think really this is probably, as the famous Winston Churchill would say, it's not the beginning of the end, it's probably the end of the beginning of the research that we're hoping to do for children who have pediatric ocular surface inflammatory diseases. And with that, I'll finish here. Thank you. I want to see if there are any questions or comments or in the audience. I also stop sharing so I can see the chats online as well. Yes, Dr. Goldberg.
So it seems to me like, BKC may be a final common pathway for a lot of different, immunologic or biologic processes that we don't understand well. So I guess what I'm wondering is, even if you can come up with a, agreed set of criteria that allow you to make the diagnosis, are you really diagnosing a disease? And if patients, positively fit your paradigm of making the diagnosis, does that group respond differently to treatment than red-eyed patients that don't meet your criteria? In other words, how does it really, if you drill down, how does it help you clinically when you develop these schema to make the diagnosis?
Yeah, and I think that's a excellent question, Dr. Goldberg. So the question really is so boiled down to is that, do we think pediatric peripheral keratoconjunctivitis is one condition or not? And by after doing the sort of the definition paper with the diagnostic panel, and now that we are looking into our own clinical series, which is ongoing right now with our current pediatric fellow, Eli, and also a few others, I'm starting to think that actually pediatric BKC is probably not a condition or not a disease, but a syndrome. It's more like a collection of conditions that looks like each other, but they seem to have two distinctive groups. And I think actually the BKC suspect group may have been just forever peripheral conjunctivitis and never developed keratitis, where some other people, they come in with keratitis, they bad scarring and very poor corneal health. And those are the ones that are true BKC that maybe in the old literature, we've always been referring them to as patennular keratoconjunctivitis. And they may have very different treatment pathways. And certainly in my own clinic now, if I see a child who have peripheral conjunctivitis, do not have any corneal involvement, I would treat them mostly with topical drops. Steroid start with, and then immunosuppressant later on if I have to maintain control. Whereas those who, among those who have corneal involvement, I find that oral antibiotics such as oral macrolides, or if the older ones, tetracyclines, those are the people that will respond very, very importantly to those agents and actually achieve control. So I think that's an excellent question. It also exposes the lack of knowledge of our part. I think, I was talking to Dr. Mendino many years ago and say, hey, you've done this before. How can I look into it more? And I think looking at the pathogenesis eventually would be very important. More on that maybe next time. I can't tell you what we're doing on that one. So hopefully one day we can actually decipher what is causing all this thing. But yes, great question. Thank you. I don't see any other questions in the audience, and I don't see any other questions on the Zoom. So with that said, thank you so much, and I'll finish off today. Have a good evening.